So I'm going to shut up and hand over to our first speaker, who is one of these H-index centurions, all the way from Italy. He has written a number of incredible papers, is considered one of the sort of godfathers of ITU. He is Professor Giovanni Landoni. And like I say, it's an absolute privilege to have him come to this rather small meeting over in Florida, and somebody that's quality is quite remarkable to have. So I will hand over to Professor Landoni. Thank you.
Good morning to everyone. Thank you very much for the introduction and for the presentation and the invitation. And I come from San Raffaele Hospital and University. If you don't know the man if you don't recognize the man on the top left, he is Professor Alfieri, one of the edge-to-edge mitral repair technique, who is still working in the hospital. I am an anesthesiologist and ICU physician. I don't have any conflict of interest to disclose. Today I'm going to talk about proteins and amino acids. I have several disclosures which are not going to affect my talk of today. Thank you very much. I'm going to present you the work of hundreds of colleagues worldwide. Here are just a few of them. And most of the thanks go to Professor Rinaldo Bellomo. If you work in the field of ICU, you know him very well. Unfortunately, he died few hours ago. And so all the ICU community is a bit sad about it. But today I'm going to show you this fantastic paper, which was inspired by him. You see him as a last author. So it was published in the New England in the past summer. And it is a randomized trial of 3,500 patients who underwent cardiac surgery with cardiopulmonary bypass. So you know very well that cardiac surgery is extremely frequent. I still don't know if it is 1 million or 2 million procedures worldwide. I find different papers saying different things, but you know that acute kidney injury is extremely frequent. We don't speak so much about it because there is little or nothing that we can do about it. Let's say that the world does not speak much about acute kidney injury. So acute kidney injury is more frequent than acute myocardial infarction, is deadlier than acute myocardial infarction, but nobody in the population, the lay people, knows about it because there is no prevention and no clear treatment. So our patients undergoing cardiac surgery have multiple reasons to have acute kidney injury, and the cardiopulmonary bypass is, of course, is likely the most important of all. And for sure, there is a reduction by approximately 50% of the renal blood flow when the patient enters into the cardiopulmonary bypass. So there is a huge problem and apparently not available solution. Okay, there is goal-directed perfusion. Ranucci is working few kilometers from my hospital, again in Milano. Fantastic data, probably a reduction in acute kidney injury. There is hematocrit that is important, and there is a range of hematocrit that is important not to cause further additional organ damage. There is pulsatile CPB that has reached the commercial level without a strong data. What I'm saying that these things are very good, very clever. We are probably doing them or going towards them, but there is no large, randomized, double-blind trial to support them. So let's go to the point. Many of us don't know that the glomerular filtration rate can increase in response to stimuli. And this stimuli is amino acids or proteins. So we know very well that the heart can work better, the lungs can work better if we go for a run, if we do physical exercise. But at school, they don't teach us that also the kidney can work better. And so there is the possibility to do a nephron recruitment and to increase the renal blood flow together with hyperfiltration. And this is done by amino acids, an infusion of amino acids, probably also a protein load can have the same effect. The mechanisms of action are multiple. They are very clear. We don't know which is the most important one, but there is a combination of vasodilatative effect at the renal level. Some of them nitric oxide mediated, but altogether, the kidney is happy. He receives more blood, and he hyperfiltrates, and he is better oxygenated when he has received an infusion of amino acids. If you want to study the mechanism of action in detail, you can go to this editorial published in this beautiful journal. Why is it beautiful? Because I was recently appointed editor-in-chief, so I have to mention it at least. When did this story started? It started in the 70s, so in the last millennium, in the New England Journal of Medicine. At that time, it was possible to go to the New England Journal of Medicine with a 53-patient randomized trial, post-operative patients, randomized to amino acid or not, and acute kidney injury progression and mortality were reduced when patients were receiving amino acids. What happened in the last 50 years? So only a dozen minor papers were published, but all beautiful and all went in the same direction. Amino acids infusion is beneficial for the kidney. So these data are small or middle-sized, but they support the background to perform the large randomized trial that we recently completed. So which patients did we include in this trial? Almost everyone. So almost every patient entering into the cardiac surgical theater and planned to receive a cardiopulmonary bypass was included in this trial. The notable exception is patients with less than 30 of glomerular filtration rate. 3,500 patients. When did we start the treatment? So I think this is very important. So after entering to the theater, after inducing general anesthesia, after positioning the central venous catheter. So these are patients that started the treatment 1 hour before the cardiopulmonary bypass. If your surgeon is particularly fast, a few minutes before going into cardiopulmonary bypass. So this is something of extreme interest for the perfusionist community. The study was double-blind, and what did we give to these patients? So we give something that is called isopuramine 10%, which is commercially available in Italy, but I recently discovered that this is not the case in the majority of the countries worldwide. So at the end of the presentation, I will show you a couple of products that are very, very similar to this product that we used in our trial and which is extremely cheap. In Italy, a bottle of half a liter costs something like €5. So extremely cheap product. There is a mix of 15 amino acids. We don't know which amino acid is the good one. We don't know which is the right combination of amino acids. From books, we know that glycine and arginine are those that most likely have these vasodilatory properties at the renal level. The trial was performed in Italy, Croatia, and Singapore. And we administered this solution at 40 milliliters per hour. 40 milliliters per hour. The infusion lasted 30 hours. So we started immediately before cardiopulmonary bypass, and we continued for a median time of 30 hours. I think this is another important point. So this is a low dose, short-term infusion of amino acids. And this is the important result. So the primary outcome, which was acute kidney injury according to the KDIGO definition, was reduced, both clinically and statistically significantly. So from 31 point something to 26 point something. This means a number needed to treat of 21. So every 21 patients entering into the cardiac surgical theater and receiving a low-dose short-term infusion of amino acids, one of these patients will have an acute kidney injury prevented thanks to this treatment. And even more importantly, look at what happened to stage 3 acute kidney injury that is extremely clinically relevant. Here we have a 50% reduction in stage 3 acute kidney injury. So I find this to be the most important finding of our trial. What happened to other outcomes, to secondary outcomes? So apparently there is no difference. But when you look at the data in this way, you see that also renal replacement therapy was reduced in patients receiving amino acids. So the trial was only 3,500 patients, so it was not big enough to see a reduction in renal replacement therapy, which luckily is uncommon after cardiac surgery. What about safety events? What about effects on other organs? Absolutely no difference in any other clinically relevant endpoint. So there is a beneficial effect on the kidney, and if you administer amino acids in the theater and in the ICU, which are highly monitored and controlled situation, you don't have side effects. So the problem is big, and we now have an available solution. Which are the take-home messages of this presentation? So you know very well that acute kidney injury is very common, but we didn't have solution till a few months ago, at least with level 1 evidence. Amino acids can increase renal blood flow, glomerular filtration rate, medullary and cortical oxygenation, recruit renal functionally serve. So overall, when the oxygen content was measured in animals receiving amino acids, that was increased. So the kidneys are working more and they are happier. We had several small trials over 50 years that documented the beneficial effect, a promising beneficial effect, and now we have a large trial with a number needed to treat of 21 and a 15% relative risk reduction. The paper is in the New England Journal of Medicine. If you want to make a picture, I think this is the slide, because visual abstract can summarize beautifully everything in a single slide. If you remember something like patients with chronic renal failure should not eat protein, or they should not eat a lot of protein, that is correct, but this is a completely different scenario. So we have patients with chronic kidney disease who should go on following their limited protein diet, and we have patients with or at risk for acute kidney injury where a short-term low-dose infusion of amino acid is beneficial. So these are two completely different settings, and I like to say that this is not a nutrition trial. This is a pharmacological trial where amino acids had a vasodilatory effect on the kidneys. Which is the future and which is the present? So I think the present is every patient entering into a cardiac surgical theater and planned to go cardiopulmonary bypass should receive this treatment. A low-dose, short-term infusion of amino acids worldwide. I think the future is to collect data in several other settings where acute kidney injury is common and not yet adequately studied, and we did several publications, subgroups, editorials, reviews. We put all of them here. So if you want to read them all, I put all the PDF directly at this link. Now I'm going to show you a couple of the most interesting subgroup analysis that we performed. So probably you are asking yourself, what about patients with chronic kidney disease? I mean, not those under 30 that were excluded from the trial, but what about those between 60 and 30? And the answer is that every patient in this trial benefited from the amino acid infusion. And surprisingly, the effect is increased in patients with a glomerular filtration rate less than 60, but more than 30. Remember, more than 30. The number needed to treat is reduced to 14, that I think is quite impressive. So every 14 patients with chronic kidney disease receiving the treatment, you will have one patient who will not develop the acute kidney injury thanks to the amino acids. And can you guess which is the subgroup of patients who benefited most? So there is one subgroup of patients which is small, but who had a fantastic benefit from this treatment. And the group is those patients with a temporary mechanical circulatory support. So patients who had a difficult weaning. So I'm talking about patients with intra-aortic balloon pump, vein arterial ECMO, Impella. So those few patients had a dramatic reduction in acute kidney injury with the number needed to treat of 6. We have published it, and in our ICU, every patient with an intra-aortic balloon pump, an ECMO, or an Impella receives a 1 or 2 days infusion of amino acids these days. You know that Impella has now fantastic results in support of reducing mortality in cardiogenic shock, but with an extremely high rate of acute kidney injury and renal replacement therapy. This might definitely help. In Europe, the guidelines were being published exactly in the period when the paper was published. So in the European guidelines, you already find the sentence, the intravenous infusion of a balanced mixture of amino acids should be considered perioperatively, including during CPB, to reduce the occurrence of AKI. And this is the only suggestion that is given to prevent acute kidney injury. And now a slide that I ask you not to take a picture because the data are unpublished. They are just submitted. What happens when our patient has a prolonged CPB? In our study, a prolonged CPB was 92 minutes. It means 50% of the patients had more than 92 minutes CPB time. And the results are, again, impressive. So patients with prolonged CPB, or let's say with CPB more than 92 minutes, have an increased effect of amino acids with a number needed to treat of 12. I hope it's not a message for me to go fast to the end because I'm being on time. I'm doing a fantastic presentation and I'm being on time. And we have several other manuscripts, including a cost analysis, which is not yet published, but has been performed, documenting that the product is so cheap that it is also economically advantageous to administer it on a routine basis. Of course, we invite you to collaborate with us on this important topic. This is email of myself. I promise you to give you a practical slide. So you will go back to work within a few days and you will not have the isopuramine that we have in Italy. So you are a bit unlucky. So with our colleagues, we went through all the amino acidic solution that we found on the web, and we found that there are two other solutions that are commercially available worldwide, and that they are similar to what we used. So this is the name. I don't know them because we don't have them in Italy, as far as I know. But these are two practical messages. Remember that the dose should be low and the time of administration should be short. Why? Because urea is produced when you administer amino acids. If you do it for a short period of time, you have no side effect. If you do it for a prolonged period of time or at a high dose, you will have the side effects of urea administration, and we still don't know which is the cutoff. If you read carefully our trial, we administer amino acids up to 72 hours, but under the practical point of view, the majority of patients were discharged from the ICU very soon, and so our administration length was 30 hours. So what I suggest is to give a 36 hours, 1.5 days of amino acids is likely the best. If you are interested in further collaboration with us, these are other ongoing randomized trials, all academic, that have participation from colleagues worldwide. In particular, we are studying short-acting beta blockers in the cardioplegia as a cardioplegia adjuvant. We also give it immediately before the cardioplegia. So thank you very much for your attention and again for the invitation.
Try that. Yeah, that's better. I think that's what they call a masterclass in presenting evidence. So I don't think there's any doubt that, you know, amino acid infusions are actually the way we should all be looking at. And I think to my mind, it's looking at how can we augment what we do in terms of flow, because we often concentrate on, you know, what flow we're doing or how much oxygen delivery, but actually there's a lot more to it that we could potentially utilize with these different techniques and kind of adding into our sort of program. And I suppose the thing then becomes an idea of precision medicine within perfusion. Do you see that essentially one day as a group we'll have the ability to sort of not only run the pump, but we'll be able to dial in sort of specific sort of concentrations of different drugs into how we manage it, and then it becomes more a case of an individual way of managing the patient, rather than just a sort of general guideline of, well, you should do about this much of an infusion, for example.
So what I showed you is very simple to be performed. Probably it is not so linked to precision medicine, because even if we found several subgroups who benefit most, it is sometimes difficult to anticipate which patient will need the temporary mechanical circulatory support, which patient will have a prolonged CPB, who knows? I mean, so I think this should be part of routine clinical care, with a few notable exceptions of patients with severe chronic kidney disease. I think the perfusionist community can be definitely protagonist in this, because you have guidelines, you are in the theater. Most likely what we are seeing is a protective effect of the negative effect of the cardiopulmonary bypass. I think it should be you telling the world if we should start the treatment before CPB, or if starting it at CPB start is beneficial all the way. I mean, there are so many questions that are available. That under the practical point of view, this is something so simple to be performed. You can put it here in the pump. I mean, wherever you want.
Just going to pause on.
Thank you. If you have a time for a brief question. Gio, Tony Hodges from Scottsdale, Arizona. Good to see you again. Thank you for memorializing our mutual friend, Ronaldo Bellomo. For the crowd that doesn't know, probably the most published intensivist and AKI physician in the nation, from Melbourne, Australia. So just passed away, and a good friend of ours. So quick question. I think you just answered the first one about timing of starting a therapy to condition the kidney. Secondly, in a perfusionist audience, the effect of neosynephrine, phenylephrine given in the circuit on AKI and the catecholamines on AKI. We're kind of playing push-pull a lot. You know, I think as we can attempt to decatecholamine our patients, a lot of that is, you know, behind the ether curtain with anesthesia. With that, some of it is in the pump. And I average, if everyone asks how much, you know, neosynephrine you give in the circuit during a standard case, and it's direct linear effect on reducing GFR, you know, and I think just an awareness campaign for this group, as we're doing one good thing. And I don't know how that was controlled in your study, and how you would comment maybe in future studies in controlling that.
Yep. So yes, again, timing is of paramount importance. The scientific community at the moment, we still don't know how many minutes or how many hours does it take for this treatment to have the effect. So if some of you is interested in this topic, this is definitely a very hot topic. Vasoconstrictors are of paramount importance. What I can say is, point number one, we did not collect data on vasoconstrictors during cardiopulmonary bypass. So this data was not collected for the simple reason that it is extremely difficult to measure and collect it. At least in my center is something that is commonly done and not so clearly collected as a data. What I can tell you is this treatment has no effect on mean arterial pressure. So this is a selective renal vasodilation with no effect on mean arterial pressure. And this, I know it because we measured the mean arterial pressure and the vasoconstrictor load at multiple time points, and there were no difference between groups. And of course, I agree with you that vasoconstrictors have, on one side, a potential detrimental effect on organ perfusion. Of course, on the other side, in some patients, they have a beneficial effect on organ perfusion because they increase the MAP. The debate is going on, but of course, we should limit as much as possible the use of vasoconstrictors.
Thank you, Yogesh from the Florey Institute and Austin Hospital in Melbourne, Australia. And thank you for the tribute to Professor Bellomo. And congratulations on a fantastic study. My question to you is, we are aware that the patients that develop AKI now transition to chronic kidney disease in later life. I wonder if you have thought about doing some follow-up studies on these patients that had a reduced incidence of AKI to see whether there's a reduction in the transition to CKD, and can you comment on that?
Yeah. I think this is the question. So what we are doing has an effect on long-term renal function or not? We are doing the follow-up these days. It will be a 5 years follow-up. So the majority of the patients, they will have a median follow-up of 4 years. So I hope to have the results within few months, because it's not easy to follow these patients and to ask them to send you the last available serum creatinine. But we have the ethical committee approval, and we have people calling at the moment. So I think this is the question. I personally have no doubt about what will be the answer. So I'm sure that these patients will have a reduced serum creatinine when compared to the control group. What I don't know is the magnitude. So I don't know if it will be a 0.1 or something, but stay tuned.
Last questions from the chat. Do other organs benefit from amino acid infusions?
Yeah, so to the best of my knowledge, amino acids have no clinically relevant effect on other organs, with one notable exception, which is they increase body temperature by 0.5 centigrade. So there are multiple small randomized trials, again in the past 40 years, documenting that they can reduce shivering in the perioperative period, and that they slightly increase temperature.
Thank you. Any more questions from the audience? No, in which case I think a huge thank you to coming all the way and to the excellent talk. Thank you.